towards the end of the 90s, actually were overwhelmed. Our hospitals and clinics, doctors and nurses were all overwhelmed by the number of patients. That is why we're the first country in Africa to report ourselves at the United Nations. And that, in fact, is how the international community came to be involved with us. ACHAP was the formalization of the package of assistance measures, both in the delivery, disbursement of the financial resources, the delivery, the hosting, the provision of health workers.
When we started in 2000, 2001, Botswana's HIV/AIDS prevalence was in the magnitude of 38%. At one point, based on Botswana's small population and its population growth rate, Botswana was actually threatened with becoming extinct because of the decimation on the small population by this epidemic. Today, the HIV/AIDS prevalence is 18.5%. The prevalence remains still relatively quite high because of the massive success of the antiretroviral treatment program, which keeps lots of persons who are already infected alive and in that pool. ACHAP works to assist the government of Botswana with its comprehensive HIV/AIDS response, essentially by providing technical assistance to government agencies and parastatals for policy development, strategy development, operational plan development to assist with the direct implementation of the plans that have been articulated, and also provides technical assistance with the monitoring and evaluation of the programs that are being implemented. And then we also second staff to various ministries and parastatals to provide additional services where there is a deficiency in the existing human capacity to provide those services.
We are very thankful for the support that ACHAP has provided us in the strengthening of health systems in this country here. One of the success stories with the funding that has been put towards HIV and AIDS in this country is that we've also been able to strengthen health systems to address other conditions that we continuously face in this country, particularly those comorbidities such as TB, such as cervical cancer and so forth. We've been able to see infrastructural developments, particularly in the lab, new technologies being used. We've been able to strengthen our supply chain management system, and ACHAP has also been involved, for example, in procurement of safe male circumcision kits.
The Safe Male Circumcision project aims to assist Botswana to circumcise close to 70 to 80% of eligible males between the ages of 10 and 49. Safe male circumcision has been shown clearly to be protective of men by a factor of as much as 60%. ASA program speaks to the antiretroviral treatment program and the associated prevention to mother-to-child care transmission program, which basically enabled Botswana to become one of the first countries on the African continent to begin to provide antiretroviral drugs to persons who were infected with the virus.
Now we have almost all our clinics, almost 98% of our healthcare facilities are actually prescribing and initiating ARVs. This, I think, is commendable as we move towards universal access of HIV and AIDS treatment. One of the other important areas that we've been working closely with ACHAP in is in the area of capacity building. We've been able, for example, to train more than 10,000 of our healthcare workers on KITSO training. It's not only about providing the service, but also making sure that we provide high quality service.
KITSO is a knowledge, innovation and training shall overcome AIDS. This is a program that was developed to provide training to health professionals in order for them to be able to provide HIV care to clients under the guidelines that are provided by Botswana National ARV Guidelines. As we can see now, there are more clients who are now enrolling on ARV treatment, and more clients are beginning to realize the importance of adherence, and hopefully in future we'll have a very little number of clients who are defaulting from treatment, and hopefully will reduce the rate or the chances of most of our clients developing resistance to the HIV strains that are there in our country or in sub-Saharan Africa.
The treatment optimization project has been a community-owned and community-led initiative. Each village in the district has a community mobilizer who was selected by the community leaders and is part and parcel of the community mobilization for HIV testing. So we have a team of 37 community mobilizers in the whole district. Already within 10 months, we've been able to test 23,000 people for HIV within the district, and we have carried out over 6,000 point of care CD4 tests. And we've been able to identify HIV positive people, over 1,300 HIV positive people, and over 94% of them have been linked into care, and those who need ARV treatment have been able to obtain it.
Ke a go a checka morago ga kgwedi tse tharo. Ha ke seno go a checka morago ga kgwedi tse tharo ba tla ba mpolelela gore ke telele. Gompieno ke ile go a checka maloba ba ntha ba re ke te ke a checke ka December.
Nna ke ileng go monneng yo mogate Mr. Majika. Ke go bua le ene ke le 3 months ke enwa dipilisi ke mora ke re Mr. Majika. Ha gona nna ke bona go sena mosola cause ke nwa dipilisi TB mme ke na le bolwetse jo bongwe. Ga ba ntha re nya mme go a letlelesega gore o ka di simolola le tsone ra go cancela wa tla le mongwe yo eleng gore o nna le ene gore wa go tlhokomela wa tla go tsenela treatmenteng mme gone anonyana ga ke sa tlo ke na le matla a mantsi ke gona gore ke tšhaisa go ipile ge nyaka bona ke beile dikgonga ke a tsaya wheelbarrow ke o rwalela gore ke na le matla ga ke tsena ka mo go tsitsong ka ke tlhatlhaga metsi ba felela bongwana ke a ba tsokoletsa wa se gore hanke ke nna le ditsapo ya ka motho molong ga go tshwanele jaaka ke ne ke sikidino ne ke nna ke lapile gore ke ne ke rapamenyana ga o ke batle dijo mme gape ke sena yo ntirelang ke tla be ke emelela ke re ke a itirela gongwe be ke tsewa ke bosididi yalo ke ithusediwa ke di-neighbora.
The use of these lay councillors has actually helped to decrease the workload in the central laboratories within the hospitals, because instead of the hospitals doing CD4 tests, these CD4 tests are now being done by the lay councillors at community level.
Not only has the government of Botswana adopted, that program as the norm for carrying out services, even in other areas, the government was also able to absorb all the workforce that was trained into the public service to ensure sustainability and continuity of those programs.
As a country, every 4 years, we do a survey to update on HIV and AIDS information. The survey is called the Botswana AIDS Impact Survey. We just completed Botswana AIDS Impact Survey 4. We call it Bias 4. NACA has been working very closely with the ACHAP. We have the care treatment, we have the prevention, we have the information management and the system strengthening. And if you look at all these, the way they've been delivered, ACHAP has been very critical. For phase 1, an amount exceeding $100 million was spent. And it's very clear from the indications of Bias 4 that results were achieved. As you can see, the incidence rate of HIV and AIDS went down from 1.45 in Bias 3 to 1.35 in Bias 4. So the money was put to good use.
International global community has been speaking for a long time around aid effectiveness and growing local solutions and local organizations to best tackle local problems. I believe that ACHAP is an African-grown organization that has acquired the skills, knowledge, and experience to be able to provide solutions to Africans, and that the costs which we will use in providing international global best practice type solutions of a magnitude so much lower than what has been the traditional norm. Global initiatives need to back organizations such as ACHAP to live that dream of allowing Africans to take charge of their own destiny in providing the type of technical assistance required to enable African countries and Africans deal with their health challenges.